Hello everyone, I am myself Dr. 𝐼𝐧𝐬𝐭𝐚𝐦. I am the General Medicine Educator. So in this session, I will be discussing a very important topic in the connective tissue disorders, that is the psoriatic arthritis. So we have two important clinical scenarios. One is the psoriasis, that is a skin disorder, and then the psoriatic arthritis where there is the articular manifestations. So you have to remember that the psoriasis, that is the skin disorder, usually precedes the onset of the arthritis. So this will be the first. Which one? The psoriasis will be the first. And later you have the development of the psoriatic arthritis. So the psoriasis usually precedes the onset of the arthritis or occurs simultaneously with the skin disease in approximately 20% of cases, right? So in almost 20% of cases, it occurs simultaneously, right? Or the remaining 80%, the psoriasis will appear first and then followed by that there will be development of the psoriatic arthritis. Now if you see or if you observe the signs and symptoms of this psoriatic arthritis, the pattern or subset of the joint involvement in psoriatic arthritis, it includes the following conditions. First, it should be symmetrical polyarthritis. That means the joints on both the sides should be affected, right? It is symmetrical polyarthritis. So what is the other scenario where you can have this symmetrical polyarthritis? This will resemble the rheumatoid arthritis. So even in patients with rheumatoid arthritis, you have the symmetrical polyarthritis, right? And compared to rheumatoid arthritis, in case of rheumatoid arthritis, multiple small joints and then followed by that large joints are affected. Where in case of rheumatoid arthritis, there will be involvement of metacarpophalangeal joint, there will be involvement of proximal interphalangeal joint, and there will be involvement of metatarsophalangeal joint, and there will be involvement of the large joints after the small joint involvement. But these many number of joints will not get affected in case of the psoriatic arthritis. So in case of psoriatic arthritis, it is usually the fewer joints that are being involved. Right, the fewer joints are involved in case of the psoriatic arthritis. And the other important thing is you have an oligoarthritis that may lead to considerable destruction of the affected joints, right? So you have an oligoarthritis, right? So where you have less than or equal to 4 joints are being affected in patients with the psoriasis or psoriatic arthritis, right? And specifically, if you consider the joint involvement, like which joints are involved in case of psoriatic arthritis. In case of psoriatic arthritis, it is primarily the distal interphalangeal joints, right? The distal interphalangeal joints, they are the one which are affected in patients with the psoriatic arthritis, right? And in early stages, this may be monoarticular and often the joint involvement is asymmetrical. Right, so in early stages what happens is, right, in early stages the joint involvement is monoarticular, right, it is monoarticular and the joint involvement is asymmetrical in early stages, right, that is what you will have in early stages. And apart from that joint involvement, the other important manifestation that will accompany the distal interphalangeal joint involvement is there will be also pitting of nails, right? So you can observe that here. So this is your pitting of nails, right? This is your pitting of nails. So pitting of nails and onycholysis, right? Pitting of nails and onycholysis, frequently they accompany the distal interphalangeal joint involvement. So pitting of nails and onycholysis, right, they accompany the distal interphalangeal joint involvement. So this is about the joint involvement and what will be the accompanying features. Now we have another clinical entity called as arthritis mutilans. See, what is this arthritis mutilans? It is the severe form of arthritis, right? It is a severe form of arthritis with osteolysis, right? So that is what is your arthritis mutilans. Now we have a spondylitic form in which sacroiliitis and spinal involvement they predominate. Okay, so we also have another form of the psoriatic articular involvement, that is psoriatic spondylitis. So if you see this psoriatic spondylitis, right, it is the disorder where you have the sacroiliitis, right, where you have the sacroiliitis and the spinal involvement. Okay, so that is what is your psoriatic spondylitis, right? And in case of psoriatic spondylitis, as I'm just telling you, the sacroiliitis and spinal involvement, they predominate. And these patients with the psoriatic arthritis, they have HLA-B27 association. Right, they have HLA-B27 association, that is HLA-B27 is being positive. Okay, right. And what is arthritis mutilans? It is a severe form of arthritis with osteolysis, that is what is called as the arthritis mutilans. Next, if you observe the cutaneous lesions, see, cutaneous lesions, they are essential in patients with the arthritis. And let me tell you, arthritis is at least 5 times more common in patients with severe psoriatic skin disease. Okay, so in patients with the severe psoriatic skin disease, right, this psoriatic arthritis right, this psoriatic arthritis, it is almost like 5 times more common. Okay, right, in those individuals with severe psoriatic skin disease, arthritis is at least 5 times more common, right? Then followed by that, occasionally the patients may have a single patch of psoriasis and are unaware of its presence also, and that particular single patch, right, and about that particular single patch of the psoriasis, it is typically, it might be typically hidden in the scalp, right, it might be typically hidden in the gluteal cleft, right, or it might be typically hidden in the umbilicus. Okay, so that is what is your the single patch. Occasionally, however, patients may have a single patch of psoriasis and the individual is unaware of its presence. And that is the reason why a detailed search for the cutaneous lesion is essential in patients with arthritis of new onset. Right? If you are suspecting psoriatic arthritis of new onset, you have to do a detailed search for this particular single patch of the skin lesion. And in case of severe psoriatic skin disease, the arthritis is almost like 5 times more common, right? Next, the other important point is the psoriatic lesions may have cleared when arthritis appear in such cases, right? In some patients, what will happen is the psoriatic, this is the first point what I was telling you. What is that? The psoriatic lesions, they precede the development of the psoriatic arthritis. So, in some patients, the psoriatic lesions may have cleared when arthritis appear in such cases. Then in such case, then how can you suspect arthritis? Very important is history. History is most useful in diagnosing previously unexplained cases of monoarthritis or the oligoarthritis, right? And in the history, what all will be the clues? Number 1, nail pitting. Right, nail pitting is sometimes a clue. And the other thing is, you observe this, the sausage swelling or dactylitis. right? Sausage swelling or dactylitis. So sausage swelling or dactylitis of one or more digits is the common manifestation of enthesopathy in psoriatic arthritis. So what does this sausage swelling or dactylitis it represents? The sausage swelling or dactylitis of one or more digits is a common manifestation of enthesopathy. Right, it is a common manifestation of enthesopathy in psoriatic arthritis. So please remember, this is a very, very important point. Right? Now, what do you mean by this word enthesopathy? Enthesopathy is the disorder where you have the inflammation of tendon at the point of insertion of the bone. That is what is called as enthesitis or enthesopathy. So, how can you make out that particular patient is suffering with the psoriatic arthritis? Either by searching for the skin lesions, or by asking the history of previous skin lesions, or by searching for the pitting of the nails, or by looking for the sausage swelling or dactylitis. Next, coming to the laboratory findings in patients with the psoriatic arthritis. It is an inflammatory disorder, so ESR is elevated. And this ESR is elevated in approximately 50% of patients. Right, it is elevated approximately in 50% of patients with psoriatic arthritis. And one point you have to remember, ESR will be elevated, but if the ESR is normal, right, for suppose if the ESR is normal, this will not, or this do not rule out the diagnosis. Right, these do not rule out the diagnosis. Okay, and the other point is the RA factor and anti-CCP antibodies are not present. Right, RA factor is absent and anti-CCP right, that is also absent. See, remember your psoriatic arthritis, it is a seronegative arthritis. Right, it is a seronegative arthritis. And the other point is the uric acid levels, they are high. Right, the uric acid levels are high. And the uric acid levels are being high. What does this tells you? This will reflect active turnover of the skin. Right, this will reflect active turnover of the skin that is being affected by psoriasis. So that is what the uric acid level being high indicates. Right, it reflects the active turnover of the skin affected by the psoriasis. Next, if you see imaging in these patients with the psoriatic arthritis, radiographic findings are most helpful in distinguishing the disease from other forms of arthritis. Now, what will be that radiographic findings? So, radiographic findings, they include the following. Number one, marginal erosions of the bone. Right, marginal erosions of the bone. Then there will be irregular destruction of joint and bone. Right, irregular destruction of the joint and bone, and there will be also appearance of the sharpened pencil. And that particular appearance, we call it as pencil in cup appearance, right? So you can observe that here, right? So you can observe this particular joint, right? So this is the pencil in cup deformity. So this is a classical description of the bony abnormalities in imaging in patients with the psoriatic arthritis. Okay, now that particular changes, right, that is penicillin cup appearance, marginal erosions of the bone, right, and irregular destruction of the joint and bone. These changes, where is that you will observe? These changes you will observe in the shafts of metacarpals, right, observed in shafts of metacarpals, observed in metatarsals, right, observed in phalanges. Okay, so this is where the imaging is very important. So imaging, the radiographic findings, they are the most helpful in distinguishing the disease from other forms of arthritis, and they include marginal erosions of the bone, irregular destruction of the joint and bone, which in phalanx may give the appearance of the sharpened pencil. And such particular changes you will observe that in shafts of metacarpals, metatarsals, and as well as the phalanges. Now, we were discussing about the psoriatic spondylitis. Psoriatic spondylitis, it causes asymmetrical sacroiliitis. So you can observe that here, that there will be involvement of the sacroiliac joint in case of the psoriatic spondylitis. So this causes asymmetrical sacroiliitis, and there will be also presence of syndesmophytes. Right, and there will be also presence of the syndesmophytes. Okay, so this is what you will observe in the psoriatic spondylitis. And in psoriatic arthritis, similar to that of ankylosing spondylitis, right, in case of psoriatic arthritis, similar to that of the ankylosing spondylitis, MRI is more sensitive. Right, MRI is more sensitive in detecting the axial abnormalities than compared to that of the radiographs. Right, MRI is more sensitive than compared to that of the radiographs. Okay, so that is about the psoriatic spondylitis. So psoriatic spondylitis, it causes asymmetrical sacroiliitis and syndesmophytes, right? And these syndesmophytes are they are very coarser than those seen in the ankylosing spondylitis. And even in psoriatic arthritis also, similar to that of ankylosing spondylitis, MRI is more sensitive in detecting the axial abnormalities. Now, coming to the ultrasonography and as well as the MRI changes in psoriatic arthritis. See, ultrasonography and MRI, they are more sensitive than conventional radiographs in detecting the peripheral arthritis. So, these are more sensitive. Then conventional radiographs. Right, then conventional radiographs. So, in what way they are more sensitive? They are more sensitive in detecting the peripheral arthritis. Right, they are more sensitive in detecting enthesitis. Right, they are more sensitive in detecting the dactylitis. Right, so that is about your ultrasonography and as well as the MRI. Okay, right. Now, followed by this ultrasonography and MRI, that is the investigations, let me discuss the treatment in patients with the psoriatic arthritis. See, in patients with active psoriatic arthritis, a TNF inhibitor biological agent is recommended. So, what will be the first line agent? The first line agent will be, right, that is tumor necrosis factor inhibitor. Right, TNF inhibitor is the biological agent that is recommended as the first line agent. Now, if TNF inhibitor is contraindicated, right, if the TNF inhibitor is contraindicated or if TNF inhibitor is not tolerated, then you need to give methotrexate. Right, then you need to give methotrexate. Right, so this methotrexate, it is very much effective if the TNF inhibitor is contraindicated, and this methotrexate should be given along with the folate or folinic acid. Right, should be given along with folate or folinic acid. Okay, so that is about the story of the treatment in patients with the psoriasis or the psoriatic arthritis. Now, like there are also some small molecules, right? And what are these small molecule agents? Small molecule agents like leflunomide, right? Small molecule agents such as leflunomide, then sulfasalazine, cyclosporin, then apremilast. So these are the small molecule agents that can be given if the TNF inhibitors are contraindicated, or actually if TNF inhibitors are contraindicated, methotrexate should be the first line, right? And if the individual cannot tolerate even methotrexate, these small molecule agents can be given. Now, for suppose the patient is not responding to TNF inhibitors, or the patient is not responding to oral small molecular agents, these patients, you know, they can be treated with interleukin 12 and as well as the interleukin 23 inhibitors. Right, so they can be given interleukin 12, interleukin 23 inhibitors. Right, what are the examples of this interleukin 12 and interleukin 23 inhibitors? These examples, they include secukinumab, right, and interleukin 23 inhibitor. So this secukinumab, it is both interleukin 12 and as well as interleukin 23 inhibitor. Or we have another agent, that is ixekizumab. So this ixekizumab, it will also inhibit the interleukin 17. So let me just summarize. So in those individuals who do not respond to TNF inhibitors or small molecule agents, in them you need to give interleukin 12 and interleukin 23 inhibitor, which is secukinumab, or you can give ixekizumab, that is interleukin 17 inhibitor. Right. Now, for example, even the individual is not responding to above therapies. What are the other alternative agents we have? We have a JAK-STAT inhibitor, that is tofacitinib, right, tofacitinib, and we have another drug, that is abatacept. Right, another drug, that is abatacept. So your tofacitinib, that is JAK-STAT inhibitor, right, whereas you take abatacept, it is CTLA4 inhibitor. Right, it is CTLA4 inhibitor. So these are the drugs which are given for the treatment of psoriatic arthritis if the individual does not respond to above therapies. And what about corticosteroids? Corticosteroids, right, corticosteroids, these are less effective in psoriatic arthritis than other forms of the inflammatory arthritis. Right, these corticosteroids, in fact, they may precipitate the pustular psoriasis. Right, they may precipitate the pustular psoriasis. So this is a very, very important point, that corticosteroids, they are less effective in psoriatic arthritis than compared to that of other forms of inflammatory arthritis, and it may precipitate the pustular psoriasis during the tapering of the corticosteroids. So this completes the discussion of the psoriatic arthritis. Let me just summarize this psoriatic arthritis. See, we have two clinical entities, one is psoriasis and the other one is psoriatic arthritis. So this psoriasis, right, it precedes the onset of psoriatic arthritis, but in 20% of individuals they can occur simultaneously, right, they can occur simultaneously. And you take the joint involvement in case of the psoriatic arthritis, it is symmetrical polyarthritis, only fewer joints are affected, and it is the oligoarthritis. And in these individuals, mainly the distal interphalangeal joint is the one which is commonly affected, and it is monoarticular in earlier stages and it is asymmetrical in earlier stages. And there will be also pitting of nails and onycholysis that will frequently accompany the distal interphalangeal joint involvement. Then we have a clinical entity called arthritis mutilans, which is nothing but a severe form of arthritis with osteolysis. That is what is called as arthritis mutilans. Then we have cutaneous lesions which are essential in patients with the arthritis. And these cutaneous lesions, let me tell you, right, the arthritis, it is at least 5 times more common in patients with severe psoriatic arthritis than in those with only mild skin lesions, right? And the other point is, how can you make out that the individual had a preceding psoriasis? Either by your history of skin lesions, or by nail pitting, or by the presence of sausage swelling or dactylitis. That is suggestive of enthesopathy. Laboratory investigations, the ESR is elevated, RA factor and anti-CCP will be negative, that is, it is a seronegative arthritis, and uric acid levels may be very high. And imaging, if you see, you will observe that there are marginal erosions of the bone, irregular destruction of the joint and bone, which in the phalanx may give the appearance of the sharpened pencil, right? And such changes will also be seen along the shafts of the metacarpals, metatarsals, and as well as even within the phalanges. And another important thing, psoriatic spondylitis, it will cause the asymmetrical sacroiliitis that can be made out in the imaging. And ultrasound as well as MRI, they are more sensitive than compared to that of the conventional radiographs in detecting the peripheral arthritis. The treatment, if you see, the first line treatment will be the TNF inhibitors. And if the individual is not responding to your TNF inhibitors, then the next line drugs will be methotrexate or smaller molecular agents like leflunomide, sulfasalazine, cyclosporin or apremilast. And not responding to your TNF inhibitors or smaller molecule agents, they should be treated with ustekinumab and as well as which is a monoclonal antibody that will inhibit interleukin 12 and interleukin 23. And we have another drug that is secukinumab or ixekizumab, which inhibits the interleukin 17. And we have another drug that is tofacitinib and as well as abatacept. These are the other options if the individual fails the abotherapy. And corticosteroids, they are not very much effective. So here I'll just make a small correction. Right, the small correction is that your ixekizumab and as well as secukinumab. Right, both are interleukin 17 inhibitors, whereas ustekinumab, right, this is your interleukin 12 and interleukin 23 inhibitor. Okay, so this is about the treatment of psoriatic arthritis. So with this, I'll wind up this very important session of psoriatic arthritis. Thank you very much.